Yo, 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 week 3 immunity. Let's go. So, at the end of the last slide deck, we talked about some cases. Little Benny is 6-month-old. He's coming in for his well child check. And we decided we need to learn about his immunizations. Well, what kinds of things is he going to be immunized against? He's going to get a DPT, which has diphtheria, pertussis, and tetanus in it. It actually has acellular pertussis. That's what the little a means. Hib, which is Haemophilus influenza type B, polio, Prevnar, and HBV, which is the hepatitis B virus vaccine. Different states have different regimes, but for right now, these are the 5 we're going to talk about. So why do we give vaccines? Well, basically, it goes back to the 1700s before we even understood the germ theory. It was this really weird thing that happened where somebody figured out that a lot of patients were getting smallpox and a lot of people were dying from smallpox. It was terrible. But we figured out that if we actually infected somebody with cowpox, that they didn't get smallpox. Cowpox was a much milder disease. And so what he did was he actually went around, this guy Parker, he went around and he started infecting people with cowpox. And so when they had this infection with cowpox, they didn't get the infection with smallpox, and they lived longer. So cowpox, the scientific name is vaccinia, and therefore we started talking about people being vaccinated, and that's why we call them vaccines. So what happens when an antigen enters the body? What's an antigen? Anything that's organic material. So technically you can't be allergic to metals because they're not organic. On the other hand, there's proteins, there's polysaccharides, there's lots of different things that you can react to. So what do we do? Well, we try to keep it out of the body. We have intact skin. So it works very well as long as there's not a broken area. There are certain parasites and viruses that enter through mucous membranes, but the skin is our first line of defense. In those mucous membranes, there's a lot of antimicrobial secretions, including lysozymes. These actually seem to be best against the gram-positive organisms and less good against gram-negatives, parasites, and viruses. There is an accompanying talk here on microbiology that you should watch, obviously, as well. Stomach acid will kill lots of bacteria. There's lots of ways our body tries to keep these organisms in. Once it kind of gets into the body, our immune system has to decide, is this part of the person or is this not part of the person? And then if we identify it as non-part of the person, non-self, then there's a bunch of different mechanisms that kick in. You have lots of different weapons. We have weapons that we're born with. We have weapons that we've developed through exposure to other illnesses. And these are the innate or acquired weapons. So innately, you have phagocytosis. So basically, anytime that something invades, you have lots of white blood cells that will go and will attack it. This usually creates a non-specific inflammation and immune response. You'll get that redness, that swelling. There's other things, obviously, the natural killer cells that are a type of lymphocyte T cell. There's complements. But mostly this is a very non-specific response. Now, when your bone marrow produces bone marrow, and this all relates to epigenetics as well, so good thing to think about, it produces stem cells, and these stem cells then have the epigenome factors, such as methylation, etc., that will cause them to specialize into different types of cells. They'll specialize down usually into a lymphoid line and then the myeloid line. In the lymphoid line, there's T cells and B cells. Those are the lymphocytes. And then in the myeloid line, there's red cells, platelets, monocytes, and then granulocytes. Granulocytes are called that because they have little granules in them that take a certain stain. And then we'll talk about the 3 types of granulocytes in just a minute. And so lots of times these pluripotent stem cells, which we talk about harvesting from fetal tissue that we're trying to get to convert into cells in the brain to create dopamine for people with Parkinson's disease. Very controversial, but they are the most primitive types of cells. The granulocytes are divided into three major types. One takes a neutral stain, one takes a basic stain, and one takes an acid stain. And we call those neutrophils, basophils, or eosinophils. And the neutrophils are usually to fight bacterial infection. Basophils are basically a reaction that happens that's an allergic reaction. And then eosinophils are also elevated in allergy. Monocytes are also macrophages. Those are part of the reticuloendothelial cells and are usually not that critical in most diseases. Every time I have somebody with a dramatically elevated monocyte count, I have to look up monocytosis and go through the differential diagnosis. So complement is a system that augments your immune system. And so basically, they discovered that even when they had white cells, if they put them into a body where there wasn't any complement, nothing happened. So they have to be complementing the effect. So what do vaccines do? Vaccines try to create an acquired immunity. So basically, they want the body to be able to recognize that antigen and respond in a more focused but less inflammatory way. Basically, just go, grab those antigens, and destroy them. A lot of times they divide the immune system into cellular and humoral. I'm not really particularly going to emphasize this. I'm going to focus more on B-cell immunity and T-cell immunity. So B cells you can think of as being effected by antibodies. That means that the antibodies are what make them happen. The word effected means creates the effect. Affected means influenced by. So these B lymphocytes turn into plasma cells found in the plasma, and then they secrete antibodies, also known as immunoglobulins, which then attach to antigens to promote that destruction. Plasma cells, a cancer of plasma cells is multiple myeloma, and so you can see with people that have multiple myeloma, they can't secrete the antibodies they need. They're very prone to infection, and that's often the element that is fatal for them. We now have much more effective treatments now for multiple myeloma that use this information. But basically what the plasma cells and the antibodies do is they basically go over and they connect to whatever the antigen is so that the phagocytes can come and destroy it. These B lymphocytes also activate the complement, and they're more important if there's organisms that are floating through the bloodstream by themselves. Organisms that get into the cells that actually infect the cells are usually influenced by a different process. So what kinds of antibodies are there? Well, the two types that we usually see with infection are IgM and IgG. IgM is acute infection. IgG is what is elevated once your body has recognized that antigen and is ready to produce immunity at a later date. And so usually IgG indicates immunity, IgM indicates acute infection. IgA is also something that fights infection. It's usually a lesser important. If somebody has a complete IgA deficiency, they'll be likely to get more infections, but a lot of people will have a little bit of a deficiency without it being a major issue. IgE is elevated in the allergic responses. So if one has a response to an antigen that is not infectious per se, but that you still want to rid, those IgE levels will go up. And there are certain monoclonal antibody medicines now that are trying to bind with these immunoglobulins, the IgE, in people that have an overactive allergic response or overactive immune response. IgD, we basically never talk about. We really can't measure it. It is on the B cells. It does exist, but it's not something you really need to know. T cell immunity. So T cells are formed in the thymus, and basically they develop those T cells to attack, create a specific bacteria. So the IgG facilitates the development of certain types of T lymphocytes, and these lymphocytes will go out and attack a certain bacteria. So pertussis, for example, is a bacteria. If you've been exposed to pertussis or exposed to the vaccine, your body will have T cells that remember what it looks like. It will send out those T cells, it will attack them, and will destroy the bacteria. There's three kinds of T cells: helpers, killers, and suppressors. Interleukins are an important concept because interleukins are a type of cytokine. So cytokines basically attach to an antigen and say, hey, over here, come destroy this. The problem is that sometimes you have certain cytokines, you have too much of them. Histamine, for example, can happen in an allergy, and the body says, hey, come do this. And the problem is you get all sorts of inflammation. You get all sorts of extra blood flow, all sorts of inflammation, way beyond what the body needs to respond to that particular threat. Killer cells kill, suppressors regulate. So mature T cells and B cells have structures on their surface that they call clusters of differentiation. And these clusters of differentiation make them just appear different. And you can actually tell what some of them do. CD4 count, for example, is something that we look at in HIV. If someone has lots of CD4 cells, they're going to be able to attack and fight off HIV. Once the CD4 cells get low, they're not only going to be able to fight off that virus, there's lots of other viruses, lots of parasites, lots of fungi that it won't be able to attack and fight off. So when an antigen and an antibody combine, we call this an MHC, or major histocompatibility complex. In class 1, these are the things that make you you. So basically anything that's not you, the antibodies attack, they connect to these antigens, and then your phagocytes take it and move it away. So you go to the dentist, they aggressively clean your teeth, a few bacteria get in your bloodstream, your body recognizes them as not belonging there, and it will grab onto them. Class 2 basically does the same thing, except that some of these antigens are already phagocytized. And again, the problem is that not only can this be helpful, but if the body starts recognizing its own cells as being foreign, it'll start attacking them. So for example, in multiple sclerosis, the demyelination that happens is related to these cells attacking the myelin sheath on the nerves and basically destroying it. Same kind of thing can happen in many other autoimmune processes. The tumor necrosis factor can attack the cells of the joints and cause damage in rheumatoid arthritis. There's lots of things that can happen. So there's lots of cytokines. Many of them you will have heard of. If you look at the labeling for Flonase, it talks about at least 6 of them. So histamine and leukotrienes and interleukin-6, and there's a bunch of different cytokines. And if you interfere with those, it can actually cause the person to get an infection and have problems. On the other hand, if you interfere with the ones that are inappropriately overactive, you can help take away some symptoms that are not really helping the person at all. Interferon is related. We're not going to talk a lot about interferon until we get to multiple sclerosis. And then tumor necrosis factor is a signal for inflammatory response. It happens in cancers, and that's why it's the tumor necrosis factor. On the other hand, it also happens in rheumatoid arthritis and various other joint problems. So there's lots of different things that TNF is important with. Crohn's disease has excess TNF, and we end up having to block some of that. So colony stimulating factors. So basically, your body has a response. If you have inadequate white blood cells, and especially granulocytes, your body will put out some more GCSF, granulocyte colony stimulation factor. We've now synthesized these so that if someone is getting cancer chemotherapy and their white cells are dropping down low, we can actually give them an injection of this. One of the brand names is Neupogen because it stimulates the neutrophils. And it can really help make those folks have higher white counts and more likely able to fight off infection. So back to Ben. Here's his immunizations. Diphtheria. Well, diphtheria is not a condition that we see very much in the United States just because most people are immunized. They're gram-positive rods. If you get diphtheria, you'll get this nasty gray coating on your throat. It'll usually progress to myocarditis and heart failure. There are things that look a little bit similar to diphtheria that are called diphtheroids that sometimes are described in a throat culture, but true diphtheria is rare. So basically, the vaccine, when you give the person the vaccine, stimulates the person to create B cells that will recognize this and then create the cells that are necessary to go out and phagocytize it and get rid of it. We give it by giving the vaccine at regular intervals. We give DPT at 2, 4, 6, 18 months in preschool. And then we also give a TD booster at about age 12, and then some people give it every 10 years, others give it just once in adulthood. But note that for TD, the D is a small d because it contains much less diphtheria. So I think that's a really important thing to look at. When we give that 12 or 13-year-old shot, the D and the P are small letters because it contains much less diphtheria and much less pertussis than do the 2, 4, 6, 18-month and preschool vaccines. So what is pertussis? Pertussis is a bacteria. It's a gram-negative coccobacillus, so not all bacteria fit neatly into one category or another. It has characteristics of both a cocci and a bacillus. It usually presents in adults as a 2-week cough. They feel like they just don't feel good. It's very frequently diagnosed as bronchitis. Sometimes we put people on a Z-Pak. Z-Pak is actually the drug of choice for pertussis, azithromycin. And so it goes away and they feel better. In a baby, about 1 out of 100, it will actually not only cause this cough will progress to a severe respiratory illness and pneumonia, and 1% of them do die. So this is why we're so aggressive with immunizing and especially trying to immunize all the people around these babies. This is why we give moms and dads Tdap, and this is why I always encourage grandparents to make sure that their Tdap is up to date. We switched to the acellular form because the cellular form was causing too much of a reaction. It was creating too much of a response. They'd get fever, they'd get inflammation, and occasionally kids would even get seizures and rarely would even die. By taking the actual cell and just putting bits of the antigen into the vaccine, we seem to get just as good immunity, but we don't have these severe reactions. Millie Finch is 80 years old. She was working in the garden, cut herself on a rusty nail. She says she's never had a tetanus shot. Is this possible? Well, it actually is, because the vaccine didn't come out till 1938. Most people have had the vaccine. Most older men got the vaccine when they went into the military for World War II or Korea or Vietnam. But it is possible that you could have an elderly woman that had never gotten the vaccine. Again, not likely, but is possible. In that case, we would have to think about a short-term medicine. Normally we give the tetanus as I had described previously. You could test an immunoglobulin. You could do a tetanus IgG. But we never do because it's just easier to give the shot. If someone's never had the tetanus vaccine, you have to give them hypertet, tetanus immune globulin. So this is an immune serum that is taken from people that have these cells that will destroy the tetanus and given to a person that doesn't have them so that they then will have this passive immunity for a matter of weeks or months. It wears off. If they get exposed again a year or two later, they'd have to be given it again. But this is why usually if we have somebody and we give them immune globulin, we'll often give them whatever the vaccine is that goes with it. Hib, or Haemophilus influenza type B, is a gram-negative rod. We used to see a lot of cases with ear infections. Some of these would progress to meningitis. It was kind of a nasty disease. It's a little bit harder to treat for antibiotics because it is encapsulated, so it does need to have a stronger antibiotic. But we rarely see it now because we do give the Hib vaccine. Polio was a virus. We switched away from the oral polio vaccine to the injectable polio vaccine just because about 8 or 10 kids per year were getting polio in the United States. Now, granted, there's 350 million people. 8 or 10 cases is not a high number. On the other hand, we have almost completely eradicated polio from the world. And so therefore, even 8 or 10 cases is not something that we want to deal with. So we did switch over to the injectable vaccine, which is a dead vaccine. The live vaccine, as noted, did rarely actually cause the disease. Prevnar is a vaccine that covers streptococcal pneumonia, and not just that, but strep pneumoniae, which is a certain type of bacteria. It's a alpha hemolytic strep rather than the beta hemolytic strep, which causes strep throat. There's 85 known strains. We give something called Pneumovax to the elderly, which has 23 strains in it. We give the Prevnar to kids, even though it's only got 13 strains in it, just because it's a polysaccharide vaccine. Pneumovax is a polysaccharide vaccine and does not work as well as the Prevnar, which is a conjugate vaccine. So you'll often see Prevnar abbreviated as PCV13 and then the other as PPSV23. So hepatitis B virus, hopefully you all know about this. Hopefully you have all had it. You know it's a blood-borne illness. You know that it travels to the liver and can cause lifelong infection. Hepatitis C is basically curable at this point. Hepatitis B is easily managed with medication, but is still a lifelong disease at this point. We cannot cure it. Now Mary is a 3-year-old girl. She was playing with a bat. She had several scratches. Well, going back to what we've just learned, we're going to use something that gives her short-term immunity. So we're probably going to give her some rabies immune globulin, some RIG. And then we're also going to give her the longer-term vaccine. Obviously, if we could catch the bat, we'll send it off to see if it is infected with rabies. But it does take a little while usually to get those results back. So in the majority of cases, this child will have gotten the RIG and their first dose of HDCV. The easiest way to decide, to be honest with you, in these types of cases is to call the Maine CDC and have them help you. In New Hampshire, to be honest with you, I assume that there is a similar resource that you can get an immunologist or an epidemiologist to help you. I practice in Maine, which is why I would call Maine CDC. But you're going to probably need somebody to kind of help you work through this. Almost always rabies vaccine is only available in an emergency room. And so if you work in an ER, you'll know what resources you need. So there's lots of other vaccines. The Veravax is the chickenpox vaccine, the MMR, the hepatitis A vaccine. There's 2 types of meningitis vaccine at this point, the regular and the MenB. And then there's yellow fever. You need a special stamp. You need special certification to be able to do the yellow fever vaccine. So those people would have to go to a vaccine clinic. So more on complement. So basically there's a cascade for C1 through C9. You can actually do a complement of CH50 level, and it'll give you a general feeling of how much complement they've got. Or you can test specific. Lots of times we'll test complement 3 and complement 4 because those are important ones. And again, if someone lacks complement, even though they have enough white cells, they're not going to be able to fight off the infection. There's an alternative, an lectin pathway, but we're not really going to go over these particularly other than to say that they exist. So when the immune response is excessive or exaggerated, these are hypersensitivity reactions. And there's 4 types, 1, 2, 3, and 4, very logically named. Type 1 is the one you hear the most about. Usually when we say a type 1 reaction, we're mostly thinking about anaphylaxis, where there's this severe burst of histamine. Histamine basically causes this weird shock, because what happens is you have this horrible vasodilatation out in the periphery, and then they can't get enough blood and oxygen to their brain and vital organs. In a type 1 reaction, IgE, which is found on the surface of mast cells and basophils, which we'll talk about when we talk about the CBC, but they're pretty much the same thing, can basically cause this histamine reaction and response. You usually do not get it the first time you're exposed. This is why when somebody's stung by a bee the first time, they may have a minor reaction, and then the second time they'll have possibly anaphylaxis. Type 2 is related to destruction of cells. We don't see this very often. There's a pulmonary disorder called Goodpasture syndrome. There's certain types of hemolytic anemia. When it comes up, you'll look it up. Type 3 are immune complexes. So we often don't identify this as a type 3 hypersensitivity reaction, but rheumatoid arthritis, systemic lupus, there's lots of different autoimmune processes that work through a type 3 reaction. Type 4 reaction is a delayed response. It's mediated by the T cells, so it takes a while to come out. You rub yourself with poison ivy, you look fine. A day or two later, you don't look so fine. You have this nasty rash. There's some things that can cause a type 4 reaction later on that are like respiratory antigens, but usually it's less severe. So any other questions, definitely post them on Canvas, and I'm going to give you a little bit of a case, not a very extensive one, but this will at least get us started on the discussion board. And Morris Pierce is 82. And he's coming in and he just feels tired. He doesn't feel good. So we're going to talk about all of his differential, but we're going to mostly focus on infectious causes. So please post this discussion on the discussion board.